Welcome back on the AM show. In the course of this week, we've contemplated different areas of our national life where we'd like government to throw the spotlight, where we'd like government to focus and make our lives better. We started by talking about that section that takes care of, or, on which everything else is leveraged, the economy. We've also spoken about sanitation. We've contemplated education. Today, we contemplate health and agriculture, but we start from the health standpoint. A whole lot to contemplate, especially with hospitals in certain areas where you cannot even get paracetamol, the most basic health commodities. Well, we start off that discussion today looking at what government should be focusing on in the course of 2024. Joining us for a conversation, we have Dr. Kwame Sarpong Asiedu, a CDD fellow on health. He joins the conversation. Later, we'll also have Dr. Fred Adomako-Boateng, Bono East Director of Health, later joining the conversation. But let me say a very good morning to Dr. Kwame Sarpong Asiedu. Good morning, sir. Hello,
Doc. Raymond. Can you hear me?
I can hear you now. I wish the volume were a bit better.
Is it better?
It is. It is. Thank you so much, sir. And Happy New Year. I think that's in order.
Same to you.
If I asked you to reflect on 2023 health-wise, and maybe give your scorecard for this administration in terms of health, what would you say?
Well, I would say that 2023 wasn't eventful. And I say that because we obviously had an eventful 2020, 2021, and less so 2022, thanks to the COVID pandemic. So 2023 wasn't eventful. But it was also marked by some stark realities. If you remember, it was in 2023 that we had the vaccine shortages and all those things. And we also had the issues around...
You're talking about the childhood vaccine shortages.
Yes. And we also had the issues around the renal units and large conversations around dialysis and other things. We had conversations around the National Health Insurance Scheme and the fact that their fund flows were limited. So you would say that the realities of our health system, what actually underpins our health system to run properly, were put under the spotlight in 2023. And often it wasn't brilliant, but the underlying factor for all the things that came under the spotlight cannot really be attributed to health on its own without talking about the financial, underpinning that drives healthcare. So for me, that is how I'll summarize 2023, that there were issues in health, but they could all be traced back to financing.
I see. And what would your score then be for this administration, looking at these lapses that you speak of?
Well, if you talk about scoring them, I would say that it was average. I wouldn't say that there was anything that was marked. And I'm scoring them average on the basis that we are coming out of 2020, 2021, and 2022. And I'm also looking at it from the standpoint that if you look critically, there's nothing that really stands out. You can talk about the issues around the fact that Agenda 111 was started, how far did it get, is it moving as quickly as it is, were the 18 months target that were set initially met? And so if you want to go into all those things and you go on and on and on, you tend to realize that, no, you cannot give anything above 50%. Because, it's difficult to tell me to score a health system that has capped almost 85% of the inflows that goes to the National Health Service and moved it into the consolidated fund when we have laws that stipulate that money should go to the National Health Insurance Fund directly. You cannot expect me to score it any higher than 50%.
Now, there has also been the issue of hospital facilities, yes, that cannot even offer you paracetamol. For which reason, in some places like in the Sisala West constituency, people would cross over into Burkina Faso. And it's not just there. In many different parts of the country, you wouldn't even get paracetamol. In other instances, they stock these, but they are unwilling to let go of them because of the delay in payments by the National Health Insurance Authority, as the claims have been made time and again. Then we can talk about the La General Hospital brought down, still not built. In recent times, there has been talk about some work ongoing there, but this is the twilight of this administration after it had been pulled down how many years ago? 2.5, 3 years ago? So there are all of those to look at as well. You mentioned the renal department at Kolebu, among others. When you look at that picture, what do you feel we could do better with in terms of 2024? What should our approach be to health?
Well, you see, the Ghana Health Service with the Global Fund and others did an audit of our health system. And I'm quite sure you saw the audit, which came out towards the latter part of 2023, which said only 5% of our consultation rooms, for example, had a full complement of consultation facilities. And for me, that is a worry, which means that it is highly likely that if you went into any of the 95% other consultation rooms in public hospitals, a misdiagnosis could occur because they don't have the full complement, not because the health professionals are incompetent, but because the tools of work are not available. So you ask me this question, and then you ask me about 2024. You see, one thing we shouldn't run away from, and that is why I underpinned everything to money, is the fact that the health system, whether it's the health leadership, whether it's the technocrats, cannot do anything if they do not have the financial backing. So we need to find out first how much money has been put into the budget for 2024 to fund health. That's a key question. And so that tells you what is the thinking of government. And I've got the approval document from the Health Select Committee. I don't know if you have it, but do you realize that in 2024, the whole financial year, what was approved for, for health is 15,577,237,278 Ghana cedis. That was what was approved. If you divide that, because when you see a lot of money like that, you would say that, well, it's a lot of money because almost 15.6 billion is a lot of money. But to get the real impact that that money can make, you have to put it into a quantifiable sum. How much money is spent per person per year by this government, or how much is the government intending to spend per person per year in health? If you look at our projected growth rate of about 2.1% per annum, as based on the statistical service, and you do the numbers, you realize that the government has committed to spend about $37 to $38 per person per year on every Ghanaian. That's all the government is committing to spend. That includes any inflows that will come out of NHIS. It includes any capital expenditure that would go into building new hospitals. It includes things that would be used to buy new equipment from these consultation rooms. And to put that in context, if you look at Ghana's global health expenditure per capita, which has been dropping since 2020, we were at around $71 last year. Out of that, the government was contributing just around $30. The private sector, which means out of pocket, you are paying out of your pocket, even though there's a health insurance scheme, was contributing 50% of that sum. So they were contributing about $36 of that sum. The remainder was being contributed by our development partners. If you look at the fact that in the 2020 budget, when the government was committed about $29, $30, what was actually approved for the government to spend was about $42 per person per year. So you have to realize that what is approved is not the same as what is dispersed.
Right.
you need to understand that of this $37, $38 per person per year, the government is going to end up spending around $26, $27. What does that mean? It means that citizens would continually have to pay more to procure health. So our health expenditure, the 50% component that is paid by citizens is likely to go up because the government is not paying up. And you then have to look at it and say, well, in a country where we have committed to deliver universal health coverage by 2030, because this is something we signed up in 2015 to do. And what does universal health coverage mean? It means that you deliver healthcare to the individual free at the point of use. It doesn't mean the healthcare is not paid for, but what it means is that finance should not be a constraint when you go to access healthcare. So in countries that are planning to achieve universal health coverage by 2020, you realize that the percentage of their health expenditure per capita that is contributed by the private sector out of pocket is dropping. Ghana's is going up and is going to go up again in 2024 based on the budget itself. So for me, that paints a gray picture in a country where spending ability of the citizens is poor. It paints a gray picture, and it's something that the government needs to relook at. And one way of relooking at it is to take off the cap on the NHIS funds. And for me, it's a key thing. But the question is, if the government takes off the cap, there will be a hole in the consolidated fund. How do they fill it? And so it's unlikely they're going to do it. So I'd say citizens must just brace themselves for a slight hike in what they pay out of pocket for their healthcare.
Wow. So citizens should brace themselves for a hike in what they pay for. Already we've seen this. Last year I had so many instances. People first complaining that the health insurance card was not delivering much and that they were paying more and more, especially in private facilities and even in public ones. And you're saying we should brace ourselves for more. What does this add to the picture? Just to give another compliment, and I forgot, when you see those, I've forgotten the proper name for those overhead lights used for surgery and the rest. There are places without them, which have been without them for a long time. Sometimes people have to use phones and their lights to perform surgery, like we've seen in some areas, not just rural areas. And that's not to say it is okay in the rural areas. But what is your thinking, Dr. Asiedu, as we wrap, on the very quick migration of Ghanaian health workers to other countries, especially the UK, Canada, the US, Australia, among other places? The numbers have been growing. I remember, I think it was the first quarter of either 2022 or 2023, 3,000 of our nurses had left, and the flow has continued. Now, some have proposed that we could go the way of the Filipino or the Philippine example, where they actually allow a quota of their health workers to go abroad. I think it is Professor Peter Quartey of ISSA, to go abroad, and then they ensure that they send remittances back to the country. So it's a sort of arrangement, and then they are bound to send some remittances or pay certain fees. Do you think that could work in Ghana's case, or are we sitting on a ticking time bomb?
You see, I've looked at the Filipino model, and the Filipino model is similar to the model that you have in Cuba. In fact, that health as a revenue driver was first started in Cuba, ironically, in a communist country. And so for a long time, if you look at the successful Brazilian universal health coverage model that a lot of people tout, you'd realize that a lot of the doctors that went in there were Cuban trained. For you to do that, you have to overtrain. What do you mean by overtrain? You know, the WHO has health professionals to population ratios.
Right.
So you need to have a health professional to population ratio that is higher than your country's requirement. So you have a surplus. You cannot export something you don't have. If you did that, then you're going to go into what happened to China when they had the Cultural Revolution, when they were sending grain abroad while people were starving in their country. That you cannot do. So yes, on paper, it is a plausible way to go. Plausible because you can make up your mind to overtrain just to export. We are not doing that. So that strategy is untenable at the moment. It's not that it's not feasible, but it's untenable at the moment because our health professional to population ratios are woefully inadequate. I can give you a few examples, and you realize that they are woefully inadequate. So for me, if you want to do these things, then we have to start planning. And without planning, we cannot do that.
Any final words for us, Doc, before you take leave of us?
You see, I am looking, my final word would be again in finance and planning. If you look at the same approval document that Parliament, the funds approved for health, if you look at the funds approved for Agenda 111, the monitoring committee of Agenda 111 are saying that they need about 1.4 billion US dollars to complete the project. What was approved in the budget is about the equivalent of 1.3 million cedis, or just around 200 million. So there's a deficit of 1.2 billion projects. And we know that we are under an IMF program. So sometimes you read official government documents and you are left wondering, why are we toying with healthcare? Based on that, there's absolutely no way those Agenda 111 projects are going to be finished because no money has been put away for them. And the documents are there, Raymond. I can share them with you, and you would see what has been approved. And it's worrying. It gives an impression that we are not serious when it comes to healthcare. And all we are probably going to see this year is health being used as a road driver, with the government trying to commission some of these very visible projects just to show that they have delivered some Agenda 111, while the main problems in the health system remain unfixed. And for me, if we allow that to happen, that would be unfortunate. So that would be my parting word.
Thank you, Dr. Kwame Sarpong-Asiedu, for your time with us this morning. We know you're on a time leash. Thank you for having joined us. Dr. Kwame Sarpong-Asiedu is a CDD Fellow on Health. Let's now continue the conversation on health by roping in Dr. Fred Adomako-Boateng. He is the Bono East Director of Health. He joins the conversation as well. Dr. Adomako-Boateng, a very good morning to you. Happy New Year.
Many happy returns to you. I heard Kwame calling you Raymond. I don't know when that meant you have gotten another extra name.
I was going to let that slide. You had to go there. I was going to let that slide, and you had to go there. Anyway, it happens from time to time. There will be a bit of a switcheroo with your name, but unless it becomes rampant, you don't really, go for it. But good to have you, and good to start the conversation on a light note. But for you, coming to you on health, what would be your assessment of the year 2023 in health? And if you could score, I know where you are as a director of health. The word I'm looking for is not coming, but it's a tricky position, and you must watch your words. But if you assessed the year 2023 health-wise, what would you say? And would you be able to score the health system on a scale of 1 to 10 in the past year?
Okay. We actually have an objective way of scoring when it comes to Ministry of Health and Ghana Health Service. We use what we call the holistic assessment, and which we do by way of peer review. The 60 regions, we will go to each other and peer review ourselves. So the holistic assessment really is a measure that Ghana Health Service we do. But if I want to give my judgment observation, looking at the context from where we are coming from, one specific one would be when the year began, we were all afraid when most of our human resource were leaving. But if you really look at some of the indicators across, we were spared. It's not that bad as we're looking at. For example, if you come to Greece, we always have our figures that I think as we go on, we will come. to them. The basic one that you look at, you have to look at maternal mortality. You have to look at the perinatal mortality. You have to look at the OPD.
Hello, Doc. All right, so we'll try to get Dr. Fred Adumaku.
These are the measures that we use.
All right, Doc.
Ourselves.
Doc,
So,
we lost you for about 20 seconds. So if you could just go back, we lost you briefly.
yes. So we have an objective way that we do it. As I said, for the holistic assessment, we have three main objectives: objective one, objective two, objective three. And in that, all the other discussions that we may be having with SEDU, they are captured in that. So one of them that we really look at, you look at the nurses to population ratio, you look at the equity index, you look at doctors to population ratio, you look at the equity index there. And these will give you an idea of how you did performance. I think I will be biased if you want me to score for Puni's and Ghana. For Puni's, I will say that we got 7/10. As they say, nobody will point the left hand to the mother's house. I think that's what I would do.
All right, but you've had your own challenges, and we'll get to your region as well. So generally, though, I still want a general assessment. Dr. Kwame Sapong-Asiedu gave a score of 50% or 5/10. What would be your general score? Looking at all the areas. I mean, there's infant mortality, maternal mortality, general mortality, services at hospital facilities, public and private. I mean, so many things in there. The lack of facilities. We heard about the renal department, the shortage of vaccines for children, among others. Where does that leave us, really? If you had to objectively score, what would you give?
Yes. Before I score, Ben, can you hear me?
I can hear you. Go ahead.
Yeah, before normally we score on, we have a ruler like up to 5 that we score. So it's either 3/5, 4/5. But even if you look at the inputs that we have just enumerated, one of them is the vaccines, one of them is the human resource. At the end of the day, you look at the output or the outcome, which is reflected in, let's see, children having the vaccine preventable diseases, diarrhea diseases, the top OPD 10, then you look at the OPD per capita. I would give ourselves 3/5. That is the ruler that normally we use. So I will give ourselves 3/5. Some regions will be better, some will be lower, but averagely, I will give 3/5.
Okay, so 3/5 would be 60%. Or 6/10. So that's your score. Hello, Doc.
Hello, Doc.
Yes, can you hear me?
Hello, Ben.
Yes, I said 3/5 is the same as 6/10 or 60%.
Yes.
Okay, all right. So let's now focus.
That's on the average.
Okay, all right. So Dr. Kwame Sapong-Asiedu 5/10 and you 6/10. Let's look now at some other aspects of our health situation and everything in between. You heard Dr. Kwame Sapong-Asiedu also complain about what amount was budgeted and even what has been disbursed as far as the health ministry is concerned. Is that a consideration? Is that a concern for you? How much we're pumping into health? Of course, we're in the grips of an IMF sponsored program, but are we doing enough? Are we committing enough resources to health? I'm sure you also heard him basically suggest that with what we're committing to health, there's no way, so to speak, we can even complete Agenda 111. What's your reflection on that? Hello, Doc. Are you with me?
When it comes to those political decisions, I think I'll be the wrong person to be answering. When we start going Agenda 1.
All right, Doc, I think maybe we may have to get you on the phone. I don't know why the connection is so patchy this morning, but we may try to get you on phone, or if the virtual connection still works, we'll try to get you back. But I interacted, and I see him still, watching along with us, Dr. Kwame Sarpong Asiedu. A short while ago, of course, he had to knock off because there were other things he had to attend to. But we still have Dr. Fred Adomako-Boateng, the Bono East Director of Health, with us. The connection is not too good, so we're going to try to find out whether we can maintain him on Zoom or connect with him via phone so we can continue the conversation from there. But it is all about health, your health, my health, the country's health. Without a healthy population, we can't work. We can't boost the economy. We can't do what must be done. So we're going to try one more time to get Dr. Fred Adomako-Boateng. If it doesn't work this time, we'll go on the phone. Doc, can you hear me, sir? Can you hear me, Doc?
Yes, I can. I can hear you, Ben.
Okay, all right. Now that we have you back, you can go to the point you were making about Agenda 111. And I only brought that up because you are in the health system. But what's your take? Okay, it doesn't look like...
Hello?
Yes, Doc. Did you get the question?
Not really, Ben. I'm having a lot of challenges over here from King Tampo.
I know. And I'm sorry about that. I'm merely saying, go ahead. You were talking about Agenda 111. Please go ahead. I don't think Doc can hear me well. So we'll just try to get him on phone, especially because of where he finds himself. The connection may not be the very best. So we'll get Doc on phone and take it from there. Still to come, some of the matters I'm going to be discussing with him, just as I discussed with Dr. Kwame Sarpong Asiedu. Doc, can you hear me now?
Hello? Yeah, I can hear you.
Okay, you can go ahead. You were talking about Agenda 111. You can go ahead.
When it comes to Agenda 111, I think the DJ and the team and then the Minister of Health will be in the position to talk about that. So that one, I wouldn't want to comment on that issue. But I don't know which other question you were asking that I can really address.
Well, I spoke about Agenda 111 and the feasibility. I was talking about the resources being allocated to health and how it may not necessarily be enough, even considering Agenda 111 and shoring up our health under an IMF program, as suggested by Dr. Kwame Sarpong Asiedu. I was just roping you into that conversation. Do you feel enough resources are being pumped into health?
Ben, that question I think is for the policymakers and the headquarters to really...
Dr. Fred Adomako-Boateng, from where you sit, you know very well whether resources are enough or not. I mean, parrying it to the health authorities, unless you say something, or unless you think you are getting enough, you can say that as well, if you think you're getting enough.
Realistically, if you want to look at Bono East, where we find ourselves, we are looking at, and for here, I believe a lot of people will listen to the context from where we are coming from. If you look at Bono East, you look at our districts, which is about 11 of them. About 80% of us in Bono East is a rural population. And so if you look at we call some places far east, you are talking about Sine East, you are talking about Sine West, you are talking about Kru East, Kru West. If you look at those dimensions, what we need in Bono East, it will surprise you, is different from what the discussion that we are having. If you come to us, if you ask me what I need as a regional director of health in Bono East, I'll be talking about 1, my chief's compounds, and 2, I'll be talking about my health centers. Because once you come here and you look at how the population is sparse, especially in that community, those communities, the distances between communities that you have to transfer and to go for, then you see that when we are talking about universal health coverage, there is no one size fits all. And that is what I want to communicate to you, that look, if you really want me to answer you that question, and the things that we in Guineas we are looking for, it will be different from maybe the discussion that we are having right now. And that's why I don't want us to even drag there, because I can go in and match and tell you some of the things that we really need when it comes to universal health coverage and then health for all. And you talk about what? Quality access. Access. So if you ask me from where I'm sitting, maybe Kumasi Accra will be different, but from where I'm sitting, if you bring Agenda 11 straight, then it will be a different discussion that we will have to go in.
Let me ask you, though, I mean, these are some of the necessities that have come up in other regions. When you look at defibrillators, for example, you look at dialysis machines, you look at incubators. How many of them do you have in your region? I mean, do you have a fair assessment? If you don't have the actual numbers, it's fine. But are you aware of how many there are, or if there are none at all?
Okay, so I believe context really matters. You remember when I came to the studio, I met Erasmus and the other, and this dialysis issue came, and we all discussing about it.
Erastus.
Yes, right. Erastus. You see, context really is the case. Ben, you remember when COVID-19 came? And normally when we are discussing, it should be context and specific things that we should be discussing. You remember when COVID-19 came, and all of us were talking about ventilators. Or everywhere you go, do you have ventilators? Do you have that? Do you have that? In the end, the issue is not about what you have or where it is. But the issue is how you are able to mobilize and then operationally use them when the need is. Look, if I give you the top 10 OPD cases and deaths in Guineas, you see that the discussion will be entirely different. And so if you ask Guineas, what do we have in terms of defibrillators and all those, the question that I will say is that we have one dialysis at Techiman, and that
one serves the entire region.
Yes.
Just humor me. What is the population of the Bono East region? I don't have the details right here, so I'll ask you. What is the average population of the Bono East region?
The population is almost 1.2 million.
So one dialysis machine to, of course, not 1.2 million, because not all of them will need it, but to cater for a population that large. Okay, all right. And then incubators?
Almost every hospital is having an incubator. And it's really coming in. For example, we had a team coming to visit Kintampo North Hospital. And I will mention the names, where we went to their emergency center. And they were asking, where did we get some of these things from? We are even having infusion pumps in some of our facilities. If you go to Atebubu Amantin Kintampo, with the support from UNICEF,
Doc, we've lost
and all others. They are having contact.
You can go ahead, Doc, if you can hear me.
Hello.
You can go ahead, Doc. I can hear you now.
So, in terms of incubators, we every hospital in Brunei, where we have hospital, Atebubu is having one. Kintampo North Municipal Hospital is having one. Jema.
Doc, we shall reach you on phone. I think that will be the best option. My next question to him was going to be how many of these were provided by government or through our health system, and how many, he just mentioned UNICEF, had been brought in from the goodwill or courtesy of the goodwill of international organizations, NGOs, and maybe people of goodwill. That also paints a certain picture, because we want to know how much our health system on its own is contributing to these. Of course, he may say what he did about defibrillators and maybe even dialysis machines, but for incubators, I mean, everywhere there are preterm babies born, and they will need some of these facilities. What happens to them? Of course, it's a broader conversation, but we're also focusing on the Bono East region, which is his region. Doc, welcome back. You're on phone now. I think it should be clearer. You were making a point.
Something about utilization. Let me give you a classical example, especially when people start to lump numbers together and see that one as the ultimate thing that is needed. You can go to a hospital and say, we don't have a CT scan. And it can be news. Go to Brunei, they have only 2 or 3 CT scans, or go to Ghana. But is that really what we need as a country? Is that really what Brunei need? And when do you really need the CT scan as compared to these? All these are discussions that should be tailored in terms of context. When you come to me as Brunei, my challenge basically will be how do I maximize the referral system so that I'll be able to really connect as to when this person or that patient will be able to be moved from there to the other issue. And that is one. And then secondly, if you come to me, for the first time last year, we had about 26 doctors coming to Ghana Health Service. That was for the first time. But the challenge that we had, for example, in Guinea, if you go to a district, like you go to Atebubu, Amantin, you go to Puri, and there is no accommodation for this doctor and the family to come there. That is what I will look. And then you get a lot of nurses coming to your facility or coming to a district where all the landladies and landlords will start increasing the amount that these nurses and doctors who are coming to support them. So you see the context then becomes different in the level of care that you are really looking at. And until we begin to really disaggregate and talk about these issues, about what is needed at A and B, and then we start talking about numbers, that has been my challenge when we talk about numbers. But it's all dynamic, look. And it's the hope on us as managers to begin to look at this context and operate in as much.
All right, I was just... Give me a straightforward answer if you can. You spoke about the incubators and the fact that every hospital has one. But you also made mention of UNICEF. How many of these were provided by outside or external organizations? So I'm talking about NGOs, IGOs, people of goodwill, rather than the health system. Of course, you know why I'm posing that question.
Okay, so, and Ben, when it comes to this issue, it's about when you talk about health, and you know, even when you give data without the permission of the Ministry of Health, Ghana Health Service, all the other partners that we talk about, they can never operate in your country. So normally when we are discussing, almost everybody is supported. So when we are supporting all these, and when they give us, it comes through headquarters once again. We have motorbikes, we have ones who all come in, it comes through headquarters. But that data, I will have to promise you that as we are speaking now, but I will definitely get it at the end of the day and let you have it, so that we can break it down, which came from this place, which came from that place, and which came from that place.
All right, thank you. I'm grateful for that. Now let's look at another crucial issue when it comes to our health. The HIV prevalence. Last year, maybe some 2 or 3 times, I hosted the head of the Ghana AIDS Commission coming through. We spoke extensively about the prevalence of HIV and AIDS and how, you know, there were these drives, even self-test kits to get people tested, among others. It appears it's on the rise again. It's been on the rise for a while. We've taken our eye off the ball. The campaigns have not really been there, or they've not been effective. And the numbers have shot up, including especially the over 100,000 who have it but do not even know and could be spreading it without knowing that they have it. In your region, the prevalence rate is even more stark, 4.8, which is higher than the national average of 2.8. My question is, when you look at that segment of our health, where have we got it right? Where are we getting it wrong? What would you like to see moving forward, generally, but also in your region, which has a pretty high concentration or prevalence rate?
So, thank you. So the data that we are discussing now, I think, is the 2021, and we are still waiting for 2021, 2022, where they really disaggregated the data in terms of the size. So if you look at Bruno, we are doing well when it comes to the rural prevalence. So if you look at the graph that we are discussing, Bruno is one of the best and the safest place to be when we are in the rural area when it comes to HIV/AIDS. We are having a prevalence of 0.6, which is way better than all the other rural sites in the country. Our challenge, as you rightly said.
Wait, what the figure you gave, is that from 2020 or the current?
Yes, the one we are discussing, basically.
Okay.
Yes, so if you look at that, they discuss those figures in terms of a rural and then urban. So what you quoted is the urban.
Right.
So normally you have to look at all these contexts that we are discussing. So when it comes to the rural issue, Bruno is doing marvelously well. But as you rightly said, the challenge has been the urban setting, where we have high figures. But these high figures are not good things that we have to boost up. Where Techiman and Kranza, in fact, one of us are leading. But then the question is, why should a rural be doing well and then the urban is not doing well? I mean, the dynamic, as you know, is if you look at Techiman, if you look at Kranza, which kind of are twin cities, and a lot of activities going on. Techiman is the central part of almost every person going to south or north will pass through Techiman and all these other issues. But then why are we not doing well? So that is what I think rightly you said. The focus and in the way that we were going in tackling the issue really came down a bit when we moved from the agency or the pandemic meter. And the self-testing issue is what we will have to look at. If you have and you don't know you have it, that is a different issue. So at the campaign, and we are believing that 2021, 2022, it should be because this year, last year, TB and HIV were on our radar. We did massive campaigns and all these. So we are looking at the next coming survey for us to do well. But then risky behavior are things that you can look at. These are very powerful commercial areas, people coming from sub-region even to Techiman, and now people moving from Techiman going to stay in Kranza. Which are not actually imaging. You have a lot of commercial activities coming on. So as you rightly said, we have to really must increase our campaign and especially self-testing. And then telling people that it's important that you know your status. Once you know your status, you yourself, you prevent getting other issues, which is good for you. If you don't know your status and you think that you don't have HIV, when it's complicated with other issues, you become a double and at times even triple burden. These are things that we are going to communicate, especially to people. But then when it comes to HIV, you know the key population that we are looking at, and the drive is preventing mothers from giving to babies, which we are doing very well. These are things that we will have to hammer on very well, and also have a way of getting other people passing through, so that when they are passing through, we have a way that people can protect themselves very well.
Now, do you have access to the self-test kits? I'm talking about the oral and the blood-based test kits. Do you have access to them in the Bono East region?
Yes. I mean, nationally, it's a program issue where they allocate based on population, as we said. So from where we don't have shortage, as we are speaking now. But then the question is the population aware? That is another thing.
That's a question I should throw back to you.
Yes. That is what we will have
and are they using them? Are they patronizing them?
Yes, that is what we are going to look at. If you ask me, to give you an honest answer, what we have to move to do is that is the population really aware when it comes to this issue, when it comes to these intervention and tools, and for them to really have them. I think that will be our drive this year, 2024 actually.
What specifically are you going to do as a regional directorate of health?
We are this year. Our target is involving the community. What we are really going to drive for 2024 is how we will mobilize the community health, 6 zones, 6 compounds, and more importantly, the network of practice as a very flagship intervention that we are going to. Because everybody lives in a community, no matter where. And these are low-hanging fruits. We have our health workers already there that can get them. And the reason why I am saying that is that, look, at times, because at the end of the day, we all go back to our houses. When we finish our work, we go to our community. So if we can empower the community, and we have a way of doing that, the community information system, we have churches, we have mosques, we have traditional leaders, authorities who are part of that. That will be our channel that we are going to do. And not even only that, we are also even thinking about, when we come to outbreak investigation, how we are going to involve the community. And a case in hand is that, for example, you are at the hospital, somebody comes to your hospital, and you see that this woman is having, let's say, a viral hemorrhagic fever or Marburg hemorrhagic one, and then you tell this woman that because of this, we are not going to let you go to the house. The woman just came to the hospital to go and buy bread to go and feed the family. So how do we also get the community earlier so that we also stimulate within the community all these emergencies so that when it comes, don't tell us that we want to use them for money. So this year, 2024, doing it is going to go into the community, involving the community. Do they really understand? Do they really get what we are talking about? And what do they want us to do for? So this is what we are going to channel through the sub-district, the 6 compound. And I think that next year, God willing, I'll be able to give you the feedback. Or even the mid-year, I'll be able to give you the feedback how far we can able to shortly.
All right, Doc. To conclude the conversation, I want you now to give us, in the next few minutes, your expectations of government, okay, in terms of health in your region and beyond. I'm looking at things like the National Health Insurance Scheme. How can it be made better to ensure that people get the health care they require? There have been claims a lot of the time that people go to health facilities and they get the bare bones of health care with health insurance, and the rest of the bills they have to foot. Here in Accra, some hospitals have been pointed to time and again. I cannot put the names out there, but people are saying that things that supposedly, even for maternal care, they shouldn't be charged for, they are getting charged for them. How do you think NHIS can fare better? There's been the shortage of vaccines for children. How do you think that can be forestalled? There are dilapidated health structures. You spoke about CHIPS compounds. Do you have any in your region? What are your expectations in that regard? Generally, what would be your expectations on the standpoint of health in 2024 from the standpoint of the Ministry of Health and government by extension?
Thank you, Ben, for giving me this opportunity. I will, first of all, want to communicate to the people of Ghana and talk to them what they have control. Then I'll come to the government. So, 1, you have control on your ability to do exercise. It's the most effective tool. And that one is not under anybody's control. So, 2024, let's exercise. 2, your diet.
Let's exercise. Okay.
Your diet. Look, you have control over what you eat when you eat. drinking. You have control over what you drink, how much you drink. Let's look at all these things. Sedentary lifestyle. I want to plead with people.
So let's break it down. When you say sedentary lifestyle, I mean, so you are sitting for long hours.
Long hours. No, you can go to market by walking, but you want to sit in your car. And then tie into exercise. Wherever you live in Ghana, you can do exercise, even in your compound house. Let's look at these things. The reason why I am saying that, and then those people who are smoking, the reason why I am saying that is that, look, no matter the situation around you, you need to be healthy to really enjoy what I'm going to talk about. And once you have that health, and which is under your control, salt, too much salt is not good for anybody. The lesser salt you take, you exhibit, the less likely of you having a high blood pressure. Too much sugar doesn't do anything to any of us. All these we have control. Please, at the end of this year, if you're a woman, go and examine your breast. Go and examine your breast. Cervical screening is there for you. Men, women, let's check our BP and our sugar. Let's check them. These are under your control. These are things that you can even walk into a health center and they will check without charging you. These are what we call wellness clinics. These are all the things that we have to do to support. Know your BP. Take a notebook and write your BP and your sugar and all these to the government. And then say to my health workers, kudos to what we have been doing. Look, if all of us were to leave Ghana, it would be a different story. But virtue of you deciding to stay, I think that is what we are saying. Let's continue to do that. And then here I'll be biased because I am one of the people in the newly created region. 6 of us, Oti, Bunui, Savannah, Northeast, Western North, and Ahafo. Please, give special care to us. We are new. We are new region. So everything that the government will think about in terms of supporting the traditional things, we should double it for us. One of the things that I would say is that, for example, if you come to Belize, give us 2 new pickers for our regional medical stores. Because what we saw as a region was that the drug issue, and I'll come to national health insurance, it's a kind of vicious cycle that we will have to address. And one of them is our ability for us to go and supervise and monitor the distant areas. Then, the work that we do as managers is not to sit at the office. It's important we go and inspect what the people are supposed to do. For the medical source, that is the plea for me, for all the newly created. And please give us 2 of them. The last one I will end, and this has been a banner on my heart. The way that we have been addressing the health care workers, let's tie. So if especially we take the census, and the census is telling us that these are the 10 most deprived districts in the country. It has made the work of the government clear. Tie salaries of health workers to that district and not to a particular group. So you can tie people who are going to go to the island community, Akodokro in Sene East, to Kodokro East, and not to Dr. Fred Adomako Boateng. So that mass doing things on a massive scale, which is not sustainable, will be addressed. Let's pragmatically see how we can tie these most deprived areas, or if there's a different thing, on a government agenda, so that it will attract people to go. We are in the country, people want to stay in Accra, people want to stay in Kumasi. In fact, when you come to Buni, people still want to stay at Setiman, Kintampo, and in Kranza, and no good. So it's It's a human thing. So how can we pool them there? This is one of the things that we can decide. Every region, let's look at 1, 2, 3, the 5 districts, and tie salary to the district and not to the person. And one thing that I will see this year, look for something that you dream of doing. I'm not saying you are going to buy a build 3-story building, you can, or buy Lincoln Navigator. No. Think about something like you want to swim, you want to do something, and tie yourself as an objective, something that you can achieve, and let that be the hook for you in 2024. And as you go enough, you work towards that. And I believe that together you'll be able to make it.
Thank you very much, Doc, for joining the conversation. To cap it all off, let me bring in Isaac Ampomah. He is the Greater Accra Regional Vice Chair, Coalition of NGOs in Health, and CEO of Concerned Health Education Project. Thank you, Ms. Ampomah, for joining the conversation. Hello, Isaac. Do we have Isaac Ampomah with us? Okay, I can hear you in bits and pieces. I think there's a problem with the connection. Hello? Hello, Isaac Ampomah. Can you hear me? All right, so we'll try and get him on the phone as we cap off the conversation. We'd also, of course, like to have a bit of a taste of what we can expect from the Greater Accra region, and especially with his being the regional vice chair for the Coalition of NGOs in Health, what his take is on the health care system and what their expectations would be in a year like this one, 2024. We'll work the phone lines to get him and cap off the conversation from that angle. Of course, our health is our wealth as a nation, and we cannot do without it. As healthy as our population is, will also impact our wealth, our productivity as a people. And it's not something we can throw under the bus or sweep under the carpet. So we're going to try to get Isaac Ampomah on the phone line. Hopefully we can do that quickly so that we can cap off the conversation on health and move on to other matters. He is the Greater Accra Regional Vice Chair, Coalition of NGOs in Health. He is also the CEO for Concerned Health Education Project. Hopefully we can get him on the line in just a little bit and take it from there. Well, unfortunately, it doesn't appear we can reach Isaac Ampomah, so we'll cap off the conversation here. Up next, we're focusing on agriculture. We're going to be talking about that space. We've been tackling them bit by bit. A few days ago, the economy and sanitation. Yesterday, education and more. And now, of course, we've focused on health. We're also going to be focusing on agriculture moving forward. We also have an update coming up, of course, in respect of that leaked IGP tape and some perspectives that have been put out by some entities concerning whether the IGP has been cleared and the others have not been cleared and whatever. We'll bring you the scoop on that as well later on the AM show. We'll be back.